Merci beaucoup, professeur Kreb, pour votre invitation. C'est un grand plaisir pour moi à parler ici aujourd'hui dans cet bâtiment magnifique. Mais je dois maintenant parler en anglais. C'est la fin de matin et mon français c'est très mauvais, bad. Alors. Merci. Okay, now in English. I want to talk a little bit, I still have the 20 minutes, yes? Yeah. To talk about economic arguments and money. Money arguments for investing in early detection and early intervention services, and indeed a little wider as well. And I want to argue that it's really important to think about these money arguments, but we have to think more about what that actually means. Because I will show some examples of why investing in early intervention is cost-effective and indeed cost-saving, but it doesn't always happen. So you saw the map. Maybe the map is a little out of date, who knows, but the point is quite genuinely, there are some countries where many services can be found and there are many countries with very little activity, or the activity is funded mainly by research grants. It's very short-term, it's not sustained. And yet we do know there is an economic evidence base supporting these interventions. So I want to say a little bit very briefly about the rationale, why this is important, and give just really two examples of cost-effective programs. But then to also say, well, there is another role for economists as well. We're not bad people. We're not just interested in counting money, but we can also help think about, well, what are the barriers to implementation? What are the barriers to increasing the availability of services? How can those arguments be made? How can we help make those arguments? And I also want to touch on something that a gentleman at the back of the room said at the beginning of the morning, which was about the role of other sectors, in that case education, and thinking about the arguments that have to be made for different sectors. Because this may be heresy to say in a medical academy, but I think it's also important to highlight impacts for other sectors. So to highlight the benefits of better education, better employment, better life chances that aren't always about managing symptoms. So thinking about these other impacts that are particularly important to other sectors that help in the process of prevention, early intervention, and indeed treatment. Now, you can say lots about big numbers. There are big numbers saying that poor mental health costs. This particular slide has been shown a lot now, I'm sure. It is an estimate of the costs of poor mental health in Europe, around 800 milliard in Europe, including around about 95 million euros for psychosis. And the point is, some of this is absolutely avoidable. So there should be strong economic arguments for taking action if we can eliminate some of the consequences of poor mental health and therefore the costs. And we can do that. We've already seen from colleagues' presentations this morning that interventions work, they are effective. So we know there are costs. And I would say that this particular slide, it may be difficult to see entirely here, but it's very conservative in what it says about costs. It doesn't talk about some of the broader impacts of living with psychosis or indeed depression or other disorders. And some of these, I think, it's difficult to put a money value on, but they're incredibly important when people make economic arguments to also talk about. Prejudice, stigmatization, the challenges for education, limited chances for personal relationships, a greater risk of homelessness. And homelessness has costs for the government, for society, absolutely for the individual, of course. More risks, sadly, of contact with the criminal justice systems. And of course, there is the scandal of life expectancy. I mean, Pat McGorry was talking about cancer and the importance of early intervention for cancer. And we all know, and everyone in this room knows, certainly the significant differential in life expectancy for people with a range of mental health problems. Yet it never really becomes a headline media news issue. It does from time to time. There are people who get it onto the newspapers, but it goes away very quickly. And yet we always talk about reduced life chances for people with cancer or trying to reduce that, or for heart disease. So life expectancy is very important as well. But the point of this is to say that these are also economic impacts, and we can think about these in economic terms, and we can attach an economic cost to some of these things. And one thing I will say now, because I will forget it and it's not in my talk, is that if there are colleagues of yours within the health professions who aren't so interested in mental health, it may be a good thing to actually emphasize the benefits to physical health of intervening early to protect a young person's mental health, because there are significant long-term physical health costs as well. And maybe for those people who are not so interested in mental health, for whatever reason, maybe emphasizing the physical health benefits may also help. Okay, now, I'm really trying to say just a few things today to keep within time, but just to emphasize some points. There are large economic costs. There are economic costs in France. There are economic costs everywhere, and we could do more to identify them. I'm not really aware of that many studies in France in English, that have looked at the economic costs of some of these issues. So that's important to say. But there may be a French literature that I sadly have not looked at, which is my mistake. But I want to say a few things very briefly. First of all, to say that there is an economic evidence base there for early intervention in particular, and to some extent early detection. Some of the original studies were what we call economic modelling studies. So you would get short-term data on effectiveness, you would look at how much it would cost to deliver a service, and then you'd work out some of the longer-term potential costs and benefits. And many of those studies were very favourable. More recently, there are now studies that are economic studies that have been conducted alongside evaluations, and indeed alongside routine clinical practice, which also are saying the same things. So, and some of this is quite long-term evidence now. So, be in no doubt, there is an evidence base that intervention is cost-effective. But it is restricted to a small number of countries. I'm sure there are others, but again, if there's an economic study on the cost-effectiveness of early intervention for psychosis in France, I don't know it. So I think there may be an opportunity to think about doing some of this work in France if you believe that will influence decision makers in France. Okay, so that's something to say. A lot of the studies that have been done, though, have focused on the health system. And of course, that's obvious, it's logical. But I want to argue that they need to go beyond the health system as well, and they also need to think about issues of system structures, financing, and so forth. Let me give two examples, two recent examples, just to illustrate what's going on. Pat McGorry already mentioned the RAISE trial in the US. There was an economic analysis done alongside the effectiveness study, and it compared the Navigate intervention, and you can see it has a number of components there, to what they call standard community care in the study. 2 years in length, it looked at health service use, it looked at impacts on housing status, and indeed on employment for these two groups, and it's about 400 people, so a reasonable size between the ages of 15 and 40. Now, this is scary, but don't worry. This is a scary picture, and I do have a pointer, perhaps. Does this work? Ah, it works. You do not need to be an economist. You don't need to worry horribly about what these pictures mean. There's a couple of things to say. One is that this is the picture on the right. Everything here in this northeast quadrant means it costs more, but it's more effective. Everything in this southeast quadrant, it costs less than community care, and it's more effective. And this is for short duration of untreated psychosis. So the message here is that if you can support people and really reduce and have a short duration of untreated psychosis, you have a 44% chance of the service being cost-saving, costing less than the community care service from a health system perspective. Okay? So early intervention not only is effective, but it can save money. And it's why it's important as well to think, to really emphasize the importance of the duration of untreated psychosis, not just for the absolute profound health benefits, but also it's for those people who are interested in money, it makes a monetary difference as well. But even if you don't intervene early, this is the longer duration, a higher duration. I forget what the lengths were, to be honest, but the point here is that most of these observations, and I should explain that this is by resampling the data many, many thousands of times and seeing what combinations of costs and outcomes you get. Most of these combinations are, again, in this northeast quadrant, which means it's more costly, but more effective. And in this particular American context, it falls within the criteria for something being considered cost-effective. It's the amount of money you're willing to spend for improvement in outcomes. This would be considered to be a cost-effective intervention in an American chance, and in an American context. And it has a 94% chance of being cost-effective. So what that means is that you can go to your policymaker and say, policymaker, we're not absolutely certain about this, but in 94% of possibility scenarios, this is actually going to be something that you would consider to be worth investing in compared to other healthcare interventions you invest in at the moment. And if you can reduce the duration of untreated psychosis, then it actually can be a cost-saving intervention to the health system alone. And these slides do not say anything about the positive impacts on housing status or employment status, which would make the case stronger. So that's one example, one recent example from a US study. A second one I wanted to mention, because I think this is actually quite an important study. It's a recent paper published in England, and it looks at what is actually going on in routine everyday practice. So it's an observational study, and I say this in which was commissioned by a local health service in Oxfordshire. Despite the map that was shown shown about the wonderful services in England, services under a lot of pressure. They are being cut, their budgets have been cut, there are staff shortages. So a particular local health research group working for the NHS commissioned a study to look at the impacts of investing, or the impacts of people who were supported by an early intervention team compared to our standard community mental health teams in this particular location in England, in Oxford. So there were more than 800 people with first episode psychosis being treated by the early intervention team, compared to almost 3,000 young people who were being supported by standard community mental health teams. And I think this slide is really quite profound. The next one. Now, basically, this is the costs. This is 3-year costs of individuals being followed up for 3 years on their use of services. Okay. Now, the individuals who were not in the early intervention team cohort never had any contact with the early intervention teams. They only used the community mental health teams. And consistently, their costs over that 3-year period are higher for the use of inpatient services. Consistently, they have significantly higher inpatient costs than individuals supported by early intervention teams. Basically, the early intervention teams reduce the amount of time with inpatient services. Okay? And the same pattern is repeated for community-based services, more or less. It's slightly higher for the early intervention teams for community, but very little differential. And again, in terms of outpatient services, there's no distinct difference. The main issue here is that early intervention teams overall were associated with lower costs because they really made a difference in terms of inpatient costs. And this particular study also looked at impacts on housing, on employment as well, and they put a value on those. And what they found, not only do you have your £4,000 a year, which these days is about €4,000, £4,000 a year in terms of savings to the health system, costs that could be avoided through better outcomes. These young people had better outcomes on the HONOS measure, but it also had wider economic impacts because they had double the rate of employment, more or less double the rate of education return as well, and they were more likely to be in stable private housing. okay? And those cost benefits, that 63 million, isn't going to be a benefit to the health system. It'll be a benefit to local authority housing services. It'll be a benefit to the economy as a whole because people have better education and indeed also better employment. So there are impacts that go beyond the health system. But I think this is really quite a powerful study, even though it's observational, because it's over a long period of time and it can demonstrate, and I should say as well, these populations were matched for the characteristics, okay? So if you think there were some problems there, they were matched to make sure they were reasonably similar in characteristics. You can see a significant difference. Now, you might say, well, perhaps the Oxford service is somehow special, maybe they do things in a better way, and the honest answer is I don't know about that, because they haven't compared it with another area. But the point is there, this, I think, is very powerful information for a policymaker, at least in England, to try and persuade them to keep on investing in early intervention. And you can point to similar studies that have been used in other places. Of course, everyone will know about Opus in Denmark. And in Denmark, Merete, Nordentoft and colleagues, they've actually invested quite a lot in making economic arguments as well. And this particular slide from one of their papers shows, again, reductions in the costs of accommodation. Logement is accommodation, isn't it? Yeah. Over time, which again is another argument for investing in Opus. And this is long-term, over a 10-year time period. Colleagues of mine in England have been looking at modelling studies again, and what they've done there is they've looked again beyond the impacts within the health service and looked at the economic value of very small changes in the risks of suicide and self-harm, homicide, sadly, as well, and the risk also of the benefits of return to work through vocational rehabilitation and supported employment. So what you can see here from this slide is that, yes, there are benefits. This is a benefit. This is a return on investment to the health system. It's a significant return. But there are also benefits from these other sectors, better employment outcomes and reduced rates of self-harm and harm to others. So it's a good investment. I hope I've tried to convince you with that. I could spend 2 hours with lots of studies showing big economic payoffs, okay? In Australia, in Ireland, in the Nordic countries, Canada, Hong Kong, I think even in Thailand now. But the point is there are lots of studies out there. But it doesn't always make a difference. Why doesn't everyone say, oh, yes, of course. You know, this is great, that's wonderful, let's do it. Well, why doesn't it have as much impact as perhaps it could? Well, I think, and this touches a bit on what Pat was saying earlier on, sometimes, at least the economists don't think about political context. We don't think about the health system context. If we're trying to persuade health systems to invest more in early intervention teams, what does that mean for the existing workforce in other parts of the health system? We have to think about those issues. Do we communicate in the right way? Maybe we show these fancy graphs, but we don't communicate in ways that the policymakers want to hear. They want to know, does it work? How effective it is? What are the cost impacts? How much is it going to cost to deliver? If you don't have early intervention teams, if that slide with France in red is right, and maybe it's not, but if it was right, then you'd have to be investing a lot just to set up teams. So there are implementation costs, establishment costs to think about. And I think economists could help a lot more in terms of making arguments about how long that's going to, how much resource and effort it's going to take, and therefore think about how sustainable a service model can be. And I also think that we can do more to support you to make arguments where you need to work with other sectors. And in particular here, I think the education sector. Because clearly, children and young people spend a lot of time in school. It's a place where risk factors might be identified, signs might be identified, people could be supported, and indeed more generally for mental health promotion, a lot more could be done. So I think more could be said about that. And with that in mind, I just wanted to briefly mention some work that we're about to finish and will be published by a body in England called Public Health England. And Public Health England is an agency within our National Health Service that focuses on public health. And interestingly enough, and I wrote this down, I was listening to other presentations, I wonder in different countries, in France, in Australia, how many psychiatrists work within public health divisions, or public health of mental health, if that makes sense? How much emphasis in psychiatry is there on being part of public health? Because maybe that would also open up more doors to think about prevention, promotion, those kinds of issues. But I wanted to show this report because this is something we were asked to do a year or so ago now, and we were asked to look at the economic case for investing in promotion and prevention. But the point was, we were asked to say, well, not only does it work, who's going to pay for it, who will get a return on investment over time, and which sectors will get that return on investment? So who's going to pay and who's going to benefit? Because one of the challenges in every area may be, you may be asking the health system to pay for support and better early intervention services, but a lot of the benefits may not just be to the health system, but to other sectors. So thinking about those issues can be important. And I'll just give an example here. This is a return on investment tool that we've developed. It's not sophisticated. It's very simple. It's an Excel spreadsheet, but it will be available to all local authorities in England and local NHS service commissioners, people who decide which services to buy. And what it shows is that, and this is an example from bullying. It's a whole school anti-bullying program. So how much money do you save? How much money do you get back if you invest in measures to tackle bullying in schools? And of course, bullying is a risk factor for poor mental health. And what we try to show there were impacts in terms of child and adolescent mental health services. So this is for one school. This is a school of 200 people in 1 year, over 4 years. You can see there are savings in terms of child and adolescent mental health services. Very conservative estimates of savings for primary care doctor contacts. That's very conservative. Impacts for the school in terms of reductions in absenteeism, because that has an impact on schools. And learning about these educational impacts is important, and impacts in terms of self-harm. And in addition to that, and I don't show it in this slide, but we've also looked at the longer-term benefits. There's good evidence in many studies that children who are bullied have poorer outcomes in adulthood, in terms of employment, education, those life chances. And that's consistent over up to the age of 50 in some studies. So there are additional savings to be made from better mental health outcomes in adulthood, better life chances, and indeed there's definitely some evidence linking avoidance of bullying or intense bullying with reduction in depression, and perhaps also with psychosis. And I'm sure other people in this room know that evidence better than me. But the point is, it's about making an argument across sectors and not just to the health system, and showing how these savings are generated over time. It takes time sometimes to demonstrate that things have a return on investment. Now, again, you might find this all very horrible because this is not about doing what's right to promote mental health, to avoid the consequences of mental health, but it can make a difference. Maybe, I don't know in France, but in England, where money now is really tight for health systems, having these economic arguments can really make a difference. A couple of other very quick points to finish. One is that I was asked to do something for the World Health Organization relatively recently about health literacy. And health literacy in schools in particular has been associated with better emotional well-being and mental health outcomes. But I was asked to focus not on the economics to the health system, but the economic benefits to other sectors. Because again, I don't know in France, but in England and in many countries, it's the school who would actually pay for these services, not the health system. So really in this particular paper, which is available online, I was highlighting examples of how making arguments about the benefits to the education system, to the school, reduced teacher stress, reduced absenteeism, better exam grades. There's some evidence on that in some studies. That can really make a difference to schools who have a budget to support mental health. So again, it's broadening the argument, but it's also about trying to reach and work with other sectors such as education. And then just a couple of other things to finish. One is that I think we can do more about, again, I mentioned this point, the cost of implementation. It's not just knowing something is cost effective, it's about the cost of implementation. We heard from Canada, from Quebec, that there's the issue about different cultures, and there are indigenous populations. Well, maybe it costs more to reach those populations. Maybe we need to invest more to get a good return on investment there. So we should look at those issues of implementation as well, because otherwise there's a danger that some people will say it costs too much, it's not worth trying to reach people who are more difficult to reach. Or maybe it's about thinking about different ways of delivering early intervention through online services. Or, for instance, there's an example in Italy now, it's called the Piano Trial, and what they've done there is take their existing community mental health teams and try and skill up them, train people within those teams to deliver specialist early intervention services to make use of the existing capacity in some parts of Italy. And there's also some evidence that I understand is under review at the moment. There's some work that's been done in England around another programme called Eden, a national study, which is demonstrating that it's actually worth investing money to actually improve the fidelity to the key principles of early intervention as well. It doesn't have to be perfect. In fact, being perfect in that particular study isn't worth doing from an economic point of view. But getting to a good level of fidelity, it's worth spending more money to try and encourage better adherence to guidelines, support for colleagues working within the system. That can make a difference as well. So I've gone through a few points very quickly. But to say a few things. You can absolutely put a cost on the impacts of psychosis and avoidable psychosis and its consequences in France. No reason why you can't do that. And I think that would be a helpful thing to do. And I know there are some studies that have been done on that in the past, but there could be more done on that, I think. And I think perhaps there's an opportunity to do more primary research here in France using this data you already have on effective interventions to look at the economic benefits of investing in measures to tackle and indeed detect psychosis. But I would also argue, and you can challenge me on this, or you may say it's different here in France, that sometimes it's about talking about things that aren't health. It's about the employment impacts, housing, education, etc. And it's trying to make an argument to other sectors that may either financially support or provide other benefits, they may be a partner in the service delivery model. And I think recognising the importance of reaching those sectors as well as the health sector may make a valuable and critical difference. So, merci beaucoup.